Okay, it's not a problem. We'll take you through everything. Okay, Zoom as well. Who's there? Leanne and Chito, how are you? I hope you all had a chance to watch the videos as well. So today I'm going to hold your hand a little bit less in the hope that you'll need to start figuring out ECGs a little bit, all right? So last week we had a very basic intro, and today we're going to dig a little bit further, all right? So this is the ECG that we are going to be looking at today, all right? Now this is actually a patient that we, is it, it's not displaying properly over there. Okay, well, I'm going to give you all the enlarged version just now, right? And if you're having trouble seeing it, you're more than welcome to come in. I'll turn the let's have a look at it there. Okay, so you can also have a look at it with me over here. So what we have is we have a 56-year-old female who came from epigastric pain that was radiating to the left shoulder and jaw, right? So the pain is in the epigastric, just about radiating up shoulder and jaw. So even though epigastric pain, generally the guys will send the patients for abdominal X-rays, you won't even think about that. Why they did the ECG was because they now have the pain going to the shoulder and the jaw. But the good is that anybody who has epigastric pain deserves an ECG. All right. Then you can explain that to you guys. What we're going to do is that we're going to analyze this ECG a little bit private. And we're going to first analyze the axis, the rhythm, the rate, and the so, okay. So here's the full ECG. So I know it's not 100% clear over there, but I hope you can follow it okay, a little bit. So the first thing we have to define is the axis. All right. So the way that we define the axis is that we put one and we can lead with the other. All right. So ideally, both of them should be positive. All right. So both of them should be. Are both of them up? So it's a normal axis. All right. So in other words, electricity is moving in the right direction. That doesn't mean everything is all right. You can have combinations. For example, lead one up, lead AVF one, lead AVF up, lead one down, or both that. Those are the only four possibilities. The axis is only but normal, left, right, and extreme right. Okay. Now we're still looking confused. Go back and watch it. Okay. So it's going to be a very simple method of working. There's actually a lot of methods. There's the thumbs method, all of the ways. Whatever you want to use, it's fine. But why it's nice to start off with the axis is that it starts giving you an idea of what's going on. So if you've got a left-sided axis, you know, also something's happening to the right side of the mind. Are you joining us or you just need to speak?
No, I just need to talk to you.
Okay. Can I just, we're just going to pause for a minute. Okay. Uzair, is that you? Are you getting tired of doing nothing at Amersfoort? He's one of our ex-interns. Okay. All right. So let's get back to it. All right. So let's talk about the rhythm now. Okay. So when we analyze rhythm, we analyze number one, the P waves. Yeah, come and stay on this. Okay, so we analyze the P waves. Right? So we look at the morphology. Now in this case, we're looking at the rhythm structure. Right? So the P waves themselves are actually quite normal. Right? They look normal, they seem okay, there's nothing much. Then we look at the PRE. Right? So it's 1, 2, 3, between 2 and 4 blocks is acceptable. Right? That's normal. Anything less than 2 is a problem. Anything more than 4 is a problem. The next thing we look at is the QRS complexes themselves. Are they narrow or wide? And here we can see they are narrow, which is good. Right? It means the AV node is getting the signal from higher. Okay. And then we look at the groupings. So are they regular? Now, in this case, they're not 100% regular. You can see the slight gaps. Right? The reason for that is something we call sinus arrhythmia. Right? So every time you breathe in, out, your heart goes slightly fast and slow. Your heartbeat is not supposed to be exactly the same throughout. That's also an issue. You shouldn't have. That means you're not breathing. Okay, so you have to have that. Okay, and the rate in this case is 1, 2, 3, 4, 5. So 300 divided by 5 comes to about 70 somewhere. In most cases, the machine will give you the rate of the 5. Now, we've got to look at each zone. Right. Now, even before we start looking at each zone, let's say we do suspect a myocardial infarction. If we have what we call it epigastric, right? So the pain is here, where's your heart? Just about that, right? So if the pain is here to the bottom, which part of the heart will be affected? Top, bottom, right, and left. The bottom part, there you go. So the bottom part is most likely right? Any of the other left-sided MRI, bilateral MRI, septal, anterior, those are the ones that give you the crushing pain, the patients start getting radiation all over, sun into the back, things like that. But inferior infarct, generally, you get this weird epigastric pain, right? A lot of patients actually die from inferior MRIs because they think they're just having severe heart attack. That's it. Or like a peptic ulcer or something like that. In the meantime, they're busy dying from myocardial infarction. So anytime you get a patient with epigastric pain who fits the profile, so generally a bit older, hypertensive, high cholesterol, leads a sedentary life, smoker, whatever risk factor you can think of. If they have a risk factor in epigastric pain, it takes you 5 minutes to do this, not more. All right. And if you're lucky and you work in a nice hospital, somebody will even do the ECG. Student. I'm just pointing at them because they with us. But you just do it. You've covered yourself medical legally, and also you've done what's best. Right? You don't necessarily have to radiation of the pain. So which are all inferior? In other words, which are the ones that are bottom of the heart? So those are 2, 3, and 8. All right. The lead 2 from this direction, inferior that direction. Right. And then what do you notice with these 2, 3, and specifically? What segment is that? Very good. And is it an elevation or a decrease? Elevation, quite a significant elevation as well. Right. Now, so we can more or less already start thinking that this may be an inferior infarct. Okay. Now, what happens is that just having ST elevations by themselves doesn't mean you've got an infarct. You've got to look through for something we call reciprocal change. Right? We're going to go through the whole ECG. Reciprocal change, basically what happens on one side of the opposite should happen on the opposite side. So to give you an example, if let's say you were standing behind it, I'm looking at him, so I push him away, he's moving away from me, but you should see him coming towards you. That's a reciprocal change, because you're seeing the opposite from the opposite side. Okay. So the next 2 leads that we have on the limb leads are lead 1 and lead 1. So lead 1 sits here. Right. Now, remember, lead 1 doesn't exist on the body. Neither do lead 2 and 3. They're what we call augmented. But its point of view is from the left directly lateral, and the AVR is from the shoulder. So these are called the high lateral because they're looking at the high lateral. So they put the high lateral part here. You're almost completely across from them. And what do we see in these 1? ST? No. This is our ST segment. What's happening to the ST segment compared to the yes, very good. It's an ST depression, right? Or a reciprocal thing. Right. Are we more convinced now that it's an infarct? Sorry. No, it's not a wheelchair. We try to look at it on all the screens, but it's not. You should put the blue lemons there, but you can actually see everything. Right. So already, after we look through all the leads, we can already more or less be quite assured that we've got an inferior and inferior infarction. Okay. So let's look through the rest of the ECG. It's kind of like finding a patient with a broken arm. You don't just stop there. You've still got to check the rest of the body. So it's the same thing with an ECG. Keep on going. Right? So AVR sits on the right shoulder. Right? AVR is often called the forgotten because it doesn't serve too many purposes. It's just looking at one side. Okay. So it may show you changes, it may not show you changes. In this case, it's not really showing any changes. It's within its normal levels. Okay. Now let's look at V1 and V2. So V1 and V2 are what we call the septal leads. They look at the septum, all right? The intraventricular septum. Okay. So what do we see in V1? What does that look like? This is your ST segment. What does it actually look like? Is it up or down? Slightly elevated because that's your what you call a neutral line, let's say your zero line. It actually looks a bit elevated. Okay. It's a possibility. Is the patient also having an infarct over there? What's going on? It's possible. But remember, V1 and V2 work as a couple. Right? And what do we see in V2? That's a neutral line. Below, isn't it? So you've got an ST depression. Okay. So we'll get that why that looks like that in a little while. But here it's already showing a possible reciprocal change. V3 and V4 are your anterior leads. Right? So remember V1 and V2 here. V3, V4. So they're looking at the anterior part of the heart. Is there anything that you notice? I know it's very tempting to say this is an ST elevation. Right? It's actually not an ST elevation. It's something we call a high takeoff. Right? In other words, it starts and just goes up a little bit. Right? And in V3 especially, it depends on age and sex. It can be a normal variant that you get a slight ST elevation. Right? But that we're not going to stress about. And V5 and V6 sit here. All right? So they're looking at the lateral side. Okay. And we said lead 1 and AV are also looking at the lateral side. So you actually have 4 leads that are looking at the lateral side. So you have those 4 leads, lead 1, VVL, V5, and V6. Right? So they're each looking at the lateral side from a slightly different point. Right? So remember, we said 1 and AVL are looking at the higher part of it. Right? But leads, oh God, what's happening here? I need to make it like an auto. I wonder if you can do that, like just do an auto. Can you? I don't know. On Zoom, you know, just that participant can just enter. You don't have to physically enter. Yeah. So in other words, we expect these 4 to give you a similar picture, but they may not always necessarily, because V5 and V6 are kind of looking through the heart that way, and 1 and AV are kind of looking from that. Right? So they can give you slightly different points of view, but majority of the time they're all the same. So V5 also has this slightly high takeoff. It's starting off from normal, and then it's going up, as compared to here, where it starts off high and just goes higher. That's an ST elevation, all right? Whereas here, it starts off as normal and just kind of goes up. That's not an ST elevation. That's a high takeoff, right? And then in V6, we also see that it's just stretched along a little. So, okay, we've decided that we've got an inferior infarct. Okay. Concepts? Anything else you're worried about looking at it? Especially when you look at leads 2 and 3. Anything you've picked up over the last 2 years? Whether you've been on the group now. I know you don't watch the videos, but so let me teach you guys something about inferior infarct. So when we say inferior, we're talking about this part. Okay. Any idea which part is sitting on which ventricle? Right. Very good. Okay. So the inferior part on the right and the posterior are supplied by very similar blood supply, whereas the left tends to have its own blood supply. Okay. So when that blood supply is cut off in any way, and we look at leads 2 and leads 3, right? Remember, lead 2 is looking at it from this point of view, slightly towards the right, and lead 3 is looking at it from the left. So can you see the ST elevation in lead 3? It's higher than what it is. Right. So what that tells us is that the right side of the heart is actually also getting cut. So it's not just the inferior section of the right, it's also going up into its right wall. So this is becoming a right-sided infarct as well. So it's not just inferior, it's right-sided as well. So now you've decided on all of that. What are you going to do? Very good, you've got it. It's like diagnosing Guillain-Barré and then you don't know what to do about it. Isn't it? You need to know what to do about it. So what are you guys going to do? Okay. Right. Okay, giving TNT, no. Okay. So you give energies there. What energies are you giving? morphine. Yeah. We can give up to 5 milligrams. We've confirmed in infarct, so we're up to 5 milligrams. Some institutions are moving away from morphine to tranquilizer, but I still keep them. Okay, and we said we're going to give oxygen. All right, so we're going to give KNT. Anything else we're going to do? Very good. Anything else you can do? Copidograph, very good. Okay, so we give that out to the patient, and our patient's going to die, unfortunately. Right, but I'll tell you why just now. Okay, don't stress. Anyway, the patient is going to die. Right. So we're going to figure out why the patient is going to die. No, don't worry. We've all killed patients with right-sided infarcts. Don't worry. Don't worry. I've got a whole graveyard full of right-sided infarcts lying. Okay. Oops, sorry. What did I do there? Can you guys on Zoom hear me? Okay. Oh yeah, it is picking up. It looked like it wasn't picking up. Okay, so let's have a look and see. This is where we get to why our patient dies. Okay. So we're going to analyze it according to what we had. You know, we didn't rush through it as well. So we said our axis was normal, right? Our rhythm, the P waves were normal. The PR interval was about 3 blocks, which is normal. QRS complex width was narrow. We had a QRS after every P we did. Were the groupings of P, QRS regular? No, they weren't, but it was sinus arrhythmia that occurs with breathing, all right? The rate was about 70 beats per minute. So the zones, we started with the inferior zone. We had ST elevations in leads 2, 3, and AVF. And as we said, the ST elevation in 3 was higher than 2, which means the right side of the heart may be involved as well, right? So AVR was within normal, V1 and V2. The ST elevation as in V1, because it looks at the right side as well, because it depends where you put it. Somebody may have put it a bit more towards the right and closer to the start. So it might be why on this particular one it's picking up more of an ST elevation, right? V2 shows a more conventional ST depression, right? V3 and V4, the anterior parts, it looks like ST elevations, but it's something we call benign early repolarizations. So those high takeoffs that we're talking about, right? And V5, V6, 1 in AVL, V5 and V6 were normal, but 1 in AVL show reciprocal changes, all right? So what else did we learn from this? We have an inferior myocardial infarct with extension to the right ventricle. What are our next steps? The 15-lead ECG, right? So you know where to get that machine? No. Okay, I'll show you where we get that machine from. Do you guys know where to get the 15-lead ECG? You don't know where it is in the hospital? All right. No, I'm just kidding. Don't worry. I'll show you where it is now. All right. So you start oxygen, morphine, aspirin, and clopidogrel, but no TN. All right. Now, it's a full discussion on its own, but let's get into it a little bit. All right. So what happens is with the right, we've got the right atrium and the right ventricle. All right. We're just talking about those two now. So what feeds into those? What comes into that right atrium? Which large vessel? All right. Well, let's just say the vena, right? Because it's superior and inferior complex and right? So the vena cava is green, right? At the end of the day. So what happens is that in order for a vein to maintain pressure, it needs to have a certain circumference, right? So it's simple. If the larger circumference, the lower the pressure. The tighter circumference, the higher the pressure. Okay. So your right ventricle is very sensitive. For your right ventricle, everybody remember Starling's. The more you stretch the fiber, the more you can contract. Right? So the more you stretch a myocardial, the more you can contract. The less you stretch, the less force. And if you stretch it too much, it also can't contract. Right? So in order to, oh, sorry, somebody else just, oh, okay. All right, sorry about that. Try and get it. Okay, so yeah, like I was saying. So we've got. I hope you guys can hear me now. I'm trying to get the speaker closer to my mouth. Sorry. I hope it picks up. But anyway, sorry. New systems. I mean, it's a USB. It's supposed to just give me a straight signal. One of those things. All right. So you've got this vena cava of a certain circumference that's providing a certain fixed amount of blood to a damaged right ventricle. Right? We've got this damaged right ventricle that's receiving that blood and trying to push out whatever it can. All right. So what's the worst thing that you can do for that ventricle right now? Is provide it with less blood. Agreed? Because if you provide it with less blood, it's going to be impossible for it to keep up even its current workload, because you're not even stretching the fibers that aren't damaged. Right? What does TNT do? Nitroglycerin, what does it do? Why do we use it for MIs? What does it do to the vessels? Very good. It vasodilates in the hope that once you dilate the vessel, the blockage you might just get some blood through that blockage. All right. So as soon as you give TNT, what happens to the superior or the vena cava? There's also a vessel. It dilates. Agreed. So it's like a tube, if you can imagine a tube. So as soon as that tube gets bigger, the pressure within it decreases. Okay. So once it decreases, what's happening to the amount of blood that's entering into the right atrium and right ventricle? It decreases, isn't it? All right. So the right ventricle now has received less. So when it pumps to the left ventricle, how much is it pumping? Less. All right. So when the left ventricle pumps, how much can it pump out? Less. So how much of blood reaches the right heart the next time? Less. So when the right heart pumps again, how much does it pump out? Even less. And then when the left ventricle pumps out, it pumps out even less. And when it gets back to the right heart, it's now even lower. So what have you done? You've started a spiral of death for the patient. So no matter what you are doing, this patient's BPs just start dropping. And the patient dies. Okay, and then you stand back and say, oh my God, it was a huge myocardial infarct. We're so sorry. We sit the patient's family down and console them. We go home, have a good night's sleep, not knowing we killed the patient. All right, no, it's fine. Like I told you, I filled a whole graveyard of right-sided infarcts. Don't stress. So just remember, right-sided infarcts, no TNT. Just don't give TNT or any sort of vasodilator or anything like that. All right. So the question is then, how do you treat it? What if your patient has got low BPs already, they are struggling? Unfortunately, when you've got a right-sided infarct, you just have to give fluids. You try and get as much volume in there as possible so that whatever is left of that right ventricle can just keep on pumping. So there's patients here that we've given up to 3 or 4 liters. I mean, that's a lot, you know, and they may get pulmonary edema. There's a lot of other things. So you have to be very careful about how we're doing it. And unfortunately, they don't respond that well to adrenaline. Right. So even though we do start it, but those are the ones that tend to go on to Dovitrax, those types of medications, you know, to try and fine tune how you actually do everything. Right. And then once you've gotten to that point, where you've given all of these things, then you need to involve the medical team where you transfer to, let's say in the Bundu somewhere, you send the patient to an appropriate medical center. So when you phone the referral center that you are, thanks. Yeah, Uzair, you're 100%, right? The decreased preload. See, Uzair used to pay attention to all my lectures. I know. Now he's sitting in Amersfoort and doing that. So they tell you to do a 15-lead ECG or an anterior 18-lead ECG, depends on who you speak to. And you put the phone down and you start panicking. You're like, what the? Are these people talking? So I'm going to show you what it is. It's actually quite simple. It's just a moniker for how we look at the right side of the heart. All right. So this is a 15-lead ECG or anterior 18-lead ECG. It just depends. Where your specialist or your MO trained, they might call it either name. All right. So all that we've done is that we've just, instead of putting all the leads on the left-hand side, we've now put the leads on the right-hand side in exactly the same configuration. So it's a mirror image. All right. The reason being, we now want to look at the right side of the heart specifically. Right. We don't want to guess, is it the right side? We guesstimated it from the V2 and 3. So what's going to happen is now when we put it on, we label it, we change everything to R. So we put V2R, V3R, V4R, V5R, V6R, just like how they did it here. And we label it as a 15-lead ECG. So there's no separate machine. It's just how you place the lead. Now look at what happens to those leads that are looking at the right side of the heart. For example, now V2, V3, V4, not so much V5 and V6 because they're a bit remote. What are you seeing now? ST elevations. All right. So in other words, now you have confirmed that it's a right-sided infarct. Okay. So right-sided infarcts, not necessarily the worst to get. The problem is that the right ventricle is very thin. So they tend to get full wall ischemia very quickly as compared to a left ventricular one, right? So they do need thrombolysis quite quickly or PCI. All right. So that was just to show you how it is. Okay. And then, yeah, I think that was about it. So do you guys have any questions or anything that you want to know? Anything that seemed quite strange? Sorry, that's just a joke to finish on, right? Because we all have it. I've done that many times. So do you understand how you have to start analyzing an ECG? All right. Now I know today there were still some blank faces. So I'll give you guys a chance again. Go and watch those videos, just on the basics. And next week, we're still going to have a look at a relatively basic ECG, but you can see how much of depth you can get even from a basic ECG when you really look at it. Okay, so still another week, cancel one night of Netflix, sit and watch those things, so that when we come back next week, at least you guys will have a bit of a clearer idea of what we're talking about. I don't want you guys to get lost. That's the important. All right, you must understand exactly why we follow the system that we follow. Because remember, you are trying to save a patient. You've only got one heart, right? It's the pump. You can't fail. Once it gives up, that's the end of it. All right. So hopefully by next week, we'll have another one. And yeah, but any other questions, anything you're worried about, anything that seems strange? I'm not such a good teacher. I couldn't have explained everything. There must be some questions, something. The one question I did get once, which was quite interesting, was what if the patient does have a peptic ulcer at the same time as they're having an MI? So treat the MI. The peptic ulcer is not going to kill them. All right, you just give them a PPI, and that's about it. Okay. The most important thing is to keep the patient alive. All right. If there's no questions, I'll release all you guys. Hope you'll have a good day, and then we'll meet back again next week Thursday. We'll have a slightly more involved but basic ECG, and we'll have a look at it. All right. Then we'll take it from there. Okay. All right. And everybody on Zoom, thanks as well. And we'll meet again next week, Thursday, hopefully.